Okay, now what is physiotherapy? I think what we need to establish is what physiotherapy is. What physiotherapy is maintenance, which is the most important in Duchenne, improvement or restoration of useful function. Improvement, we can do in some cases. Restoration, particularly after an injury or a fracture. But we know it's a deteriorating condition and we're not going to make things better in the long term. But it's about useful function, keeping going. Next slide. So physiotherapy and physiotherapist are two different things. The physiotherapist is the person, and it is not, in my opinion, the job of the physiotherapist to do stretches twice a week and then say, that's it, that is your physiotherapy, you have had it for the week, that's all you need. My personal view and my team's view is that the physiotherapist is there to help, to explain to parents, to other carers like teachers, possibly even other therapists, and the children, how to manage their Duchenne at that age and with that function of each individual child based on their whole family and the family's needs, wishes, and expectations. Different families want and need different things from the physiotherapist. Some do want just the stretches. That you would have to find a physio assistant or a school assistant or actually anybody who can learn to do stretches. That is not strictly the role of the physiotherapist. Next slide. So the problem that many physiotherapists have is that they think they're the most important person in the room. But the problem for the families is that physiotherapy is only a very small part of every day and their whole life. Next slide. Because all these people want a piece of the action. And the older the boys get, sometimes the more people are involved. So we heard about psychologists. We have speech therapists for some of the boys. We need social workers, family doctors. Many children will have multiple consultants. You will have a neurologist, a spine surgeon, an orthopedic surgeon, a gastroenterologist, an endocrinologist, a heart specialist, a respiratory specialist. All want to see the child, all have their input, all have their recommendations, and this is a lot for the family. Not every family wants to cope with that much information, that much activity. So the role of the physiotherapist is to make physiotherapy daily, fun, part of everyday life, and not a burden. I don't want parents to get to the end of the day exhausted, falling into bed and worrying that they haven't done today's physiotherapy. A family wedding, a day out, things have to take priority. But what's important is if we can fit physiotherapy into every day, then it is more likely to get done and it's more likely to be enjoyed by the boys rather than thinking, it's physio time, I need my stretches. Next slide. So what is physiotherapy? It's about maximum function now, not 6 months ago at your last assessment, not a year ago when you could do more than you could do now. It's about what we see today. How can I best use what I've got in my daily life today and for the next few months? And it's about reducing burden of care for parents because many parents struggle physically, emotionally, and it is not up to the physiotherapist to add to the guilt, add to the problems, add to the difficulties. Now, Duchenne has been known for a long time. It is written about almost as much as cerebral palsy. We know it is a deteriorating condition. There is no point in waiting until joints get tight. There is no point in waiting until we have asymmetry or curvature of the spine or difficulties. We know about Duchenne. So we need to anticipate, get in quickly, and try and minimize the problems, because it is easier to minimize than repair. Next slide. Now, the little film talked about assessment. And assessment is not possible in every situation. It doesn't always have to be formal. It doesn't always have to start with this item and finish with this item and be a burden to the child as well. Because we have to accept when the boys are getting weaker, they don't always want to get onto the floor. I will always ask an older boy, do you want to get onto the floor? And if they say no, that is fine by me, because I am not going to push a boy who does not want to struggle to get up or even fail in getting up to feel bad, to feel inadequate, to feel he has failed. Let us stick to the things he knows he can do, he is confident with, and he is positive about. This is not a test to be passed or failed. This is an assessment of what you can do. We need to use this as a guide to management. It's not just about the number that comes up at the end. Next slide. Numbers are very misleading. In every scale, there is a number that you can achieve, a maximum you can achieve. And while you are somewhere near the top, that's very positive. But parents sometimes hate. They want to know the numbers and they don't want to know the numbers because they need to know if the boys have deteriorated a lot, but ultimately they actually don't want to know. So what we have to impress upon people is that sometimes a decrease in a score may not be so important to overall activity. So that the 2 that you may lose because you can't hop is not so important if you never hop. And as adults, the only time I ever have to hop is if I get my legs stuck in my trousers when I am putting them on. So if that's such a problem, I will sit down to put them on. Hopping is not the most functional activity in life. Getting off the floor is much more important. And strategies to get off the floor more than strategies to hop. So I need to be sure that parents understand that 2 points is not necessarily the biggest problem ever. It's what has changed. And sometimes you may lose 2 points, but actually your 10-meter time or your getting up from the floor time might be almost exactly the same. So not everything changes at the same rate. Next slide. Now, as we have just heard, not all boys can comply with assessment. And we presented at World Muscle Society last year our behavior scale, which was a scale that we have now developed to assess compliance with assessment. And what we do is we score the boys, and most of the boys are absolutely fine. A diagnosis of ASD or ADHD does not stop the boys complying with assessment. What it does is it means that you have to give them more space, more time to come back to a task, change the order of the task, do things in a way that fits them. Sometimes we have to fit the assessment to the child, not the child to the assessment. And that is easy in the clinical situation, but difficult in the research situation. And that is why we need to avoid boys going on to trials when they can't cope with the rigorous testing procedures. Next slide. So what do we need to think about in the ambulant child? We need to think about contractures and stretches, weakness and exercise, mobility and function. And mobility can be crawling, walking, electric wheelchair, it doesn't matter. Mobility is getting from one place to the other place, if that's what you want to do. We need to think about spinal posture, more particularly in the younger boys who are struggling with ambulation. And we need to think about pain prevention in the children, but also in the parents. Next slide. What we are very keen on is that physiotherapy is sport, activity, play, and that a family who will exercise very often have a child who is motivated to exercise. If you're that sort of family, then your children are more likely to be enthusiastic. That doesn't mean to say if you're not a sporty family, you're not an active family. There is nothing that says that a boy with Duchenne can't have a parent with medical or physical problems as well. That means that they cannot be as active as they like. It also, we have to think about the families with 2 and 3 boys with Duchenne, or as we all know, there are families who might have a boy with Duchenne and another child with something else. So again, if we can get the families to be active, it's a positive. If we can't, let's see what we can do. Next slide. Contractures are our biggest problem from a functional and mobility point of view. But they are caused because the muscles lose their stretchability. And as the bones grow, which they do first, the muscles can't stretch to keep up. And what ends up happening is as the bone grows, the short muscle pulls the bones into the shortest position. And that's where contractures happen. So once it all starts, it all seems to get worse altogether. And that causes deformity. And it can also be caused by reliance on compensatory movements. And the most common compensatory movement in Duchenne muscular dystrophy is the boys walking on their toes. And that is an important thing. They have to walk on their toes. It is mechanically necessary when the boys are weak or tired. So we don't stop them walking on their toes. But if we don't keep the ankles stretched, then they can't put their heels down when they are not walking. And that's what then causes the difficulties. Next slide. So we know that they can appear from relatively tiny. We have boys of 3 and 4 years old with hip flexion contractures. Do not think they only appear when the boys lose ambulation. And we know that we can have long finger flexor tightness from tiny because it's the boys who crawl with their fingers bent instead of out flat. And the problem with long finger flexors is you don't find them if you don't look properly. And that's the same with hips. Of course, they're not there if you don't look for them. But when you're measuring long finger flexors, you have to put the wrist back. It's no good saying, oh, look, the hand comes straight. The hand has to be back before you straighten the fingers. Now, if they are tight from very young, stretching them will be painful and can be unhelpful because if you cause pain when you stretch, you get what we call a pain reaction, and a pain reaction is always flexion. When you're in pain, you don't spread out, you flex in, and that's what we want to avoid. So we want to avoid pain. They can occur in any joint, and that includes the neck and the spine. They can be symmetrical, but more often are asymmetrical. And depending on how quickly you're growing, so through a growth spurt, they can move more quickly. Next slide. They won't just go away. This is the big problem with contractures. You can't wake up in the morning and find they're gone. This is not like a mosquito bite that will get better if you put cream on. They need work. They need attention. Next slide. So there are many ways of managing the children, but the most important one to us is what we call active assisted stretch. The boys must be doing the work. We do a bit of self-stretch. We do some passive for the joints that are hard for the boys to stretch themselves. We stretch through position, through standing, through good sitting. We stretch through splinting, through AFOs, through knee splints, through hand splints if necessary. We use a lot of serial casting, and our orthopedic surgeon came from another hospital and was surprised by how little early surgery he was asked to do on the boys. And that is because we still serially cast them a lot. And ultimately, you may need surgery. Next slide. So we don't stretch bendy joints, it's not useful. We don't stretch bent joints that can't move anywhere, or painful joints. We never ever stretch hamstrings because we want them short. They are more effective. And unless you understand the mechanics of Duchenne, you won't understand that. And the iliotibial band will not stretch. It's fibrous tissue. Research has shown that in an adult male taken from a cadaver, a whole ITB only stretches 1 centimeter with a weight on it. It's not the ITB, it's the structures, as you can see from the picture, that feed into the ITB, particularly gluteus maximus, the big bottom muscle, the one that should be the strongest in the body, which is why women's are bigger than men, because it works so hard. But in Duchenne, it's not working hard. So it contracts and it pulls the legs and pulls the ITB, but it's not the ITB that you can stretch. Next slide. So how much force? And actually, if the boys are actively working, you should never, ever have to use force at all. They should be doing the work. If you're using force, then you are getting the benefit of the stretches, not the child. And you will get beautiful muscles and theirs will be exactly the same. But it's important to stretch slowly, to think about the range, and to think about the line that the muscle pulls in. Because sprains and ankle injuries and bad knees and painful hips often happen because you stretch too quickly, too forcefully, and in the wrong direction. Next slide. So passive stretch is more likely to benefit the person doing it, because if I stretch an ankle and I gain 5 degrees, but the boy cannot use that range because we haven't trained his muscle to use it, he'll lose it again, which is why they need to be working. Next slide. We do self-stretches. Next slide. We do a lot of serial casting. We sort of have a competition at the moment to see who has the most impressive casts. This is only a small number of our casts. Next slide. But if you're going to serially cast, you have to know what you're doing. We cast for a maximum of 2 weeks. This is an orthopedic surgeon who cast a boy with Duchenne, 1 leg, with a cerebral palsy protocol of 5 weeks, and the boy lost 13 centimeters of bulk in the muscle in those 5 weeks. He couldn't stand on that leg for 2 weeks. You can see the discoloration in the leg. You have to know what you are doing when you are serially casting. This is not cerebral palsy. Next slide. We use AFOs, but we only use fixed AFOs. We don't feel that stretching AFOs at night are useful. They're not comfortable. And we don't like the contracture control devices for several reasons. Firstly, there is a theory that prolonged stretch actually reduces function, not increases it. With one of the studies I know, the boys are asked to sit for 2 hours wearing these. I don't reckon that any ambulant child should be sitting for 2 hours unless they're asleep or in school. We want the children to be mobile. It's better for their joints and their spines. Next slide. We use a lot of these splints. We call them trilocks. They're 3 straps. There's several makes. We tend to use this particular make, but the boys who have hindfoot problems, that is the heel twists or is very mobile, the boys like these splints. They fit into a normal size shoe. They're comfortable. Their friends can't see them. They can wear them for sport and activity, and they will control the movement without stopping the boys pushing down to walk. Next slide. In a very, very few cases where the boys are exceptionally tight but still strong, we would advocate early TA release, but the boys must be very strong. And this is a tiny, tiny number of boys that this is relevant to. Next slide. So we love sport, activity, play. We feel exercise programs are not only boring, but if they're too easy or too hard, it's hard for the parents to change them. And if they are boring for the boys, then they are boring for the parents too. And I don't do boring. Boring is something that I have a big problem with. Maybe I have ADHD, but I don't like boring. Next slide. Play is exercise. Walking is exercise. A study showed that children between the ages of 7 and 10 do a minimum of 5,000 steps on a school day. To school, back from school, round the playground, round the school, round home, to the toilet, back from the toilet, to the kitchen, back from the kitchen. 5,000 steps. And if you want a Fitbit, you should be aiming for 3 as a minimum for a boy who's well ambulant. Next slide. But we don't like these games as physiotherapy. These are for after you've finished. These are for the bad days. These are for when you finish doing something active. Next slide. How much, how often is every day? Something every day. Even if you've got a really busy day, you're probably fitting some exercise in somewhere. If you're doing your self stretches when you're cleaning your teeth, you can fit something in somewhere. And that means weekends too. And some families, weekends are their most active time. Next slide. Disuse atrophy is what happens, and we'll talk about this more in the non-ambulant. If you don't use a muscle, it will get weak. We all have it. Adults, children, normal, whatever. We can all have disuse atrophy. Next slide. Okay, the good exercise is always symmetrical. It's concentric, which means you're making the muscles shorter. It's aerobic. You get a little bit warmer, a little bit breathless, and a little bit of raise in heart rate. And the good exercise is fun and motivating. It never makes the boys feel they've failed. It's never too hard, but it's not too easy. Next one. So we like swimming, we like horse riding, we like cycling, even if the bikes have to be adapted. We like boxing because it's both sides. We like martial arts. We do that in a wheelchair. Elizabeth knows that. We like basketball. We prefer anything that uses both sides. So if you've got games on a Wii style computer, it should be both sides. Next slide. We don't like asymmetrical. We don't like eccentric. It's not proven to damage muscles in boys, only in mice, but we know it's more fatiguing. So we don't encourage it. But it's no good saying walking downstairs is eccentric if you have to walk downstairs. Exercising the wrong muscle groups, which is the ones that are strongest anyway, and we don't like weights. So we avoid rugby, which many of you don't play anyway. You probably just think it's American football, but we wouldn't play that either. We don't like gymnastics or trampolines. We don't like scooters because they're very asymmetrical. And running is not productive because apart from difficult, most of the boys will end up finding that. So avoid anything that's demoralizing. Next slide. Mobility is important, and as I said, it doesn't matter if it's crawling on the floor or an electric wheelchair. We have to get it right for each child. Next slide. Posture is a problem so much these days in every child, but the phones, the tablets, the laptops, we need to start improving this posture for the whole population, but the boys particularly. The number of boys that we're finding with rounded shoulders and painful backs and necks is increasing dramatically. Next slide. We know what causes pain. We'll talk more about fractures in the non-ambulant. Cramps are variable. Severe cramps are more common in Becker, but back pain is a problem of tight hip flexion contractures and in parents, and I will chastise any parent who continues to use bad techniques lifting through back pain because they will wreck their own back. It's not the right thing to do. We have to find ways around injuring parents. They're important people too. Next slide. We use taping, we use it for sprained ankles, we use it after fractures, we use it for muscle re-education, we use it under our casts in serial casting, but it won't cure anything, it won't stop contractures, it has uses, but it's certainly not for everything. Next slide. So the take-home messages of this section are that physio programs to us are boring, they've got to be made part of everyday life. Contractures don't get better by themselves, and we use splints and positioning to stretch for the longest time or hold the best position for the longest time to avoid lots of active stretches and work that the boys don't want to do. Next slide. Children are not lazy, and I have a big argument with anybody that calls them lazy. Next slide. And no two families are the same. Everyone needs treating as an individual with individual needs. We don't give out bog standard exercise programs. We fit the program to the children, to the parents, to the family, and everybody around them. And that, for the ambulant child, is a little taster of what I could talk about for all day. So what we need to say is that what you do now is what you are preparing for the future. You don't want to wait till it's too late. We anticipate, and the better we can keep the children, the more effective any new treatments will be. Thank you.